According to the American Cancer Society, colorectal cancer is the third most common cancer in the United States for both men and women. It is greatest among males, who have an approximately 1.5 times greater risk for developing than women. Risk factors. Non-modifiable risk factors. Being old, African Americans have the highest colorectal cancer incidence. Type 2 diabetes, family history of colorectal cancer, hereditary non-polyposis colon cancer, history of familial adenomatous polyposis, personal history of inflammatory bowel disease, chronic ulcerative colitis, Crohn's colitis, having higher risk, and previous treatment for certain cancers. Modifiable risk factors: obesity and physical inactivity, smoking, heavy alcohol use, certain type of diet, example, high in red meat and processed meats, and cooking meats on very high temperatures, frying, broiling, and grilling. Pathophysiology. The formulation of colorectal cancer is a multi-step process of several genetic and phenotypic alterations of normal bowel epithelium structure and function, leading to unregulated cell growth, proliferation, and tumor development. It begins with abnormal growth of tissue known as a polyp, a grossly visible protrusion from the mucosal surface originating from the innermost wall of the colon. Genetic changes include activating mutations of oncogenes, inactivating mutations of tumor suppressor genes, and defects in DNA mismatch repair genes. Additional genes and protein receptors are believed to be important in colorectal tumorigenesis. Cyclooxygenase 2, which is induced in colorectal cancer cells, influences apoptosis and other cellular functions in the colon cells and overexpression of epidermal growth factor receptor. Clinical presentation. Signs and symptoms are extremely varied, subtle, and non-specific symptoms. Early stage of colorectal cancer is asymptomatic and detected by scanning procedures. Blood in stool is the most common sign. Warning signs include any change in bowel habits, vague discomfort, and abdominal distension. Most common signs and symptoms include nausea, vomiting, and anemia. If severe, manifested by fatigue. 20% of cases present with metastatic disease, most commonly in liver, lung, and bones. Diagnosis: perform a physical examination and obtain a careful personal and family history. Evaluate entire large bowel by colonoscopy. Radiographic imaging studies. Obtain baseline laboratory tests. Complete blood cell count. International normalized ratio. Activated partial thromboplastin time, liver and renal function tests, serum carcinoembryonic antigen, which serves as a marker for monitoring colorectal cancer response to treatment, but it is too insensitive and non-specific to be used as a screening test for early-stage colorectal cancer. Determine colorectal cancer stage at diagnosis to predict prognosis and develop treatment options. Stage is based on size of the primary tumor, T1 to 4, presence and extent of lymph node involvement, N0 to 2, presence or absence of distant metastasis, M0 to 1. Stage 1 disease involves tumor invasion of submucosa, T1, or muscularis propria, T2, and negative lymph nodes. Stage 2 disease. Disease involves tumor invasion through the muscularis propria into the pericolorectal tissues, T3, or penetration to the surface of visceral peritoneum, T4A, or directly invades or is adherent to other organs or structures, T4B, and negative lymph nodes. Stage 3 disease includes T1 to 4 and positive regional lymph nodes. Stage 4 disease includes NET, NEN, and distant metastasis. Prognosis. Stage at diagnosis is the most important independent prognostic factor for survival and disease recurrence. 5-year relative survival is approximately 91% for those with localized tumor, as compared with 12% for those with metastatic disease. Poor prognostic clinical factors at diagnosis include bowel obstruction, perforation, high preoperative CEA level, distant metastasis, location of the primary tumor in the rectum or rectosigmoid area, molecular markers, particularly MSI, 18q-DCC mutation, or LOH, BRAF, V600E mutation, and KRAS mutations are also associated with colorectal cancer prognosis. Treatment strategy depends on the location and extent of disease and goals of therapy. Surgery is generally preferred for stage 1, 2, or 3 disease and select patients with metastatic stage 4 disease. However, the benefit of surgical resection in most patients with metastatic disease is limited to symptomatic improvement. Surgery for colon cancer generally involves complete tumor resection with an appropriate margin of tumor-free bowel and regional lymphadenectomy. Radiation. There is no role for adjuvant radiation in colon cancer. However, adjuvant radiation plus chemotherapy is considered standard treatment for patients with stage 2 or 3 rectal cancer after the surgical procedure is complete. In stage 1, patients diagnosed with stage 1 colon cancer are usually cured by surgical resection and adjuvant chemotherapy may not be needed. Stage 2 and 3. Surgery is advised for stage 2 and 3 colon cancer. Chemotherapy may receive before surgery if the patient have a T4B tumor. Chemotherapy after surgery may not be helpful for stage 2 cancers, but is helpful for stage 3. In stage 3, the risk of cancer returning after treatment is high. FOLFOX or Capiox is often given for stage 3. FOLFOX regimen. FOL is for folinic acid, leucovorin, F for fluorouracil, and OX for oxaliplatin, eloxetine. Capiox regimen. Capecitabine plus oxaliplatin. If oxaliplatin is not right for the patient, other options are capecitabine alone or 5-fluorouracil leucovorin. Metastatic disease stage 4. Colon cancer most often spread to the liver and sometimes the lungs. Option 1. It starts with surgery. Surgery may consist of colectomy and metastatectomy. Local therapy to the liver or lung may be added that includes ablation and stereotactic body radiotherapy. Option 2. It starts with chemotherapy. FOLFOX or Capiox are preferred, but FOLFIRI may be received. Option 3. It starts with colectomy. Afterward, chemotherapy is received for 2 to 3 months. FOLFOX or Capiox are preferred, but FOLFIRI may be received. FOLFIRI regimen includes irinotecan with 5-fluorouracil and folinic acid. Chemotherapy. There are 5 pathways used to treat advanced colon cancer. 1. The oxaliplatin pathway starts with either FOLFOX and Capiox are the 2 options for first-line treatment. Bevacizumab may be added to either regimen. Cetuximab or panitumumab can be added to FOLFOX to treat tumors with normal RAS genes that are in the left side of the colon. However, neither is likely to work if BRAF V600E mutation is present. Oxaliplatin can cause sensory neuropathy and neutropenia. Capecitabine in the Capiox regimen can cause a side effect known as hand-foot syndrome. Dose of capecitabine may be changed at the earliest sign of hand-foot syndrome. 2. The irinotecan pathway starts with FOLFIRI. It should be used with caution and at low dose with Gilbert's disease, which impairs the liver from correctly passing bilirubin. Irinotecan should be used with caution and at a low dose if the bilirubin levels are very high in the blood for any reason. 3. The FOLFOXIRI pathway starts with both oxaliplatin and irinotecan. It is an intense regimen. Bevacizumab may be added. 4. The 5-fluorouracil, leucovorin, and capecitabine pathway starts with intense but less harsh regimens. Receiving 5-fluorouracil by infusion is preferred over bolus injection. The second option is capecitabine. Bevacizumab may be added to either option. 5. The least toxic pathway starts with regimens likely to be the least harmful to patient. Infusional 5-fluorouracil leucovorin is an option. 5-fluorouracil has fewer side effects when given by infusion rather than bolus. Another option is to take capecitabine with or without bevacizumab, cetuximab or panitumumab for left-sided tumors with normal KRAS and RAS genes. More intense chemotherapy and supportive care are second-line options. Prevention. Primary prevention, which preventing the initial development of colorectal cancer. Secondary prevention, which preventing cancer in patients who demonstrate early signs of colorectal cancer. COX-2 appears to play a role in polyp formation, and COX-2 inhibition suppresses polyp growth. FDA approved the use of celecoxib to reduce the number of colorectal polyps in patients with FAP as an adjuvant to usual care. This may delay the need for surgical intervention in these patients, but the results cannot be extrapolated to the general population. Use of aspirin as both a primary and secondary chemoprevention agent has also been studied. In a prospective randomized trial, low dose 81 mg per day, aspirin was shown to decrease the incidence of additional polyps by 19% in patients with a previous history of at least one polyp. Calcium supplementation associated with a moderate reduction in the risk of recurrent colorectal adenomas, with the prospective studies demonstrating a non-statistical decrease in adenoma recurrence, but its role as a chemopreventive agent remains under investigation. Surgical resection remains an option to prevent colorectal cancer in individuals at extremely high risk for its development, such as patients diagnosed with FAP.